So we'll be discussing about the heart failure. And heart failure is a pretty complex topic. So what we're going to do is that we're going to actually, work on building up basic foundations, and we're going to start with the definitions. Then after that, we'll discuss about the pathophysiology and the clinical symptoms of heart failure. Now, when we talk about the heart failure, right? The American College of Cardiology Foundations and American Heart Associations have a new or current definitions of what heart failure is, and that is something that you should be knowing. Now, how they define is this: that heart failure is a complex clinical it's a clinical syndrome actually, right? And why this is a complex clinical syndrome is because usually what happens is that there's a heart, right? There's some sort of abnormalities on the structures and the functional impairment you see, okay? There's a it's a complex clinical syndrome that results from, okay? That results from either structural, right? Structural, and there's a functional, right? Functional impairment is there. There's a structural and functional impairment is there. But where is the impairment? It's either in a ventricular, primarily we're talking about the ventricular, left ventricle filling, or ejections of blood. All right, you gotta know this. Primarily we're talking about left ventricle, right? So it is a complex clinical syndrome that is usually results from structural and functional impairment, right? Which causes there's a problem. There's impairment in the ventricular filling, all right? That the diastolic filling is a problem, or there is a problem with the ejections of the blood, all right? And that result into, okay? What ultimate result is that? Ultimate result is this. What about the problem? Either it's a ventricular filling or the ejections of the blood is a problem. That decreases, it causes a decrease of cardiac output is there, right? And when you have decrease in cardiac output, then what happens is that this would not able to meet the metabolic demands of the tissues, all right? When the decreased cardiac output is there, that means that what happens, your systemic tissue would not get perfused or would not get, nutrients and oxygens, right? And this is what is defined as a heart failure. So this is the definitions of it, all right? Now, usually, when we talk about the heart failures, right, I have to tell you this, that generally we talk about the heart failure that is actually something called, that results into low cardiac output, okay? Low cardiac output. But there is one exception that you should be familiar with. It is a rare, but you gotta know this, right? So there's a heart failure is there. When we talk about heart failure, most common in generally, specifically when you're doing clinical rotations or in hospital floors, usually, generally people who have heart failure, they have a low cardiac output failure, right? But there are rare group of people, right? It is a rare condition that can result into something called high cardiac output failure. And I have to tell you that about, okay? So I'm gonna put that in here, right here. So when we talk about heart failure, this is a definition, you gotta know that. After that, we'll talk about heart failure. There is two categories of it, right? There's a low, decreased cardiac output failure, decreased cardiac output heart failure, or there is an increased cardiac output heart failure. Or we can simply say this is a high cardiac output failure. Please write it down. High cardiac output failure, all right? So there are two of them. And this high cardiac output failure, right? This high output failure, so let me write it down here. This is a high, right, output failure, right? This is a rare conditions, right? But I have to mention this here quickly. Usually this is it, some book says that this is caused by there's a decrease, right? Either there's an increase in end diastolic filling pressures, or usually the increase in diastolic filling pressures, or we can simply say there's a left ventricular filling time is a problem, right? There is a decrease in what? Left ventricular filling time is there, right? So ventricle is not filling the blood properly because there's you have to propel a lot of blood so rapidly. That is why. And usually you see this high cardiac output failure in certain conditions. Like for example, whenever we say high cardiac output, this is what we're talking about. There is usually normal cardiac output is 5 liters per minute or so, right? That means that what happens, your heart is still able to propel more cardiac output, more than your normal, more than 5, it will propel like 8 something, right? But the metabolic rates are very high, right? The metabolic demands of cardiac output is, let's say, maybe like 10. And then your heart is propelling maybe like 8 cardiac output, right? 8 liters per minute. But remember, so the demands is 10, but you're actually what? You're providing 8, right? So there's a 2 liter gap is there, right? Now that means that, look, your heart is still propelling more blood, but still it's not meeting the demand of tissue, right? And that is why we call them a high output failure. And usually you see that in some condition. Like for example, you can see this in a pregnancy. You can see in a pregnancy, because in a pregnant woman, right, the mother need requires the blood, plus the mother also requires the blood for the baby, right? So it's because of that, your heart has to propel more blood out. This is the one. On top of this, there's a condition called like thyroid disease. Thyroid disease, like specifically, if I talk about, let's just say, hyperthyroidism, right? Or thyrotoxicosis. Hyperthyroidism or thyrotoxicosis. What happens is there's an increased level of T3 and T4. That means that your metabolic rates are a lot more higher, okay? Your BMI is a lot more higher. That is why, your heart goes to something called, heart has to put more blood out, okay? Third, there's a condition called like a beriberi, right? And this is where a thiamine deficiency is there, right? Thiamine deficiency is there. Even in that case too. Or 4, you should remember, severe like anemia. In anemia, what happens is hemoglobin level is usually, hematocrit or hemoglobin is low, right? So it's because of that your tissue don't get perfused properly, and that is why your heart has to propel more blood out, right? That happens. And 5th is that you must remember, right? Something called arteriovenous fistula. And even in this case, usually if there is some sort of fistula between the artery and venous, then what happens is that, the arteries and veins are like connected to one another. Usually when the blood goes, right, blood goes from the arteries and it goes to the smaller arteries and it goes to capillaries, and from the capillaries, like all the nutrient oxygen, they diffuse to the tissue, right? But if the AV fistula is there, there's a shunting of artery venous happens. The blood literally shunt from the artery to venous, and very quickly. And it's because of this, it doesn't have enough time for the blood to actually diffuse from the capillaries to get to the tissue, right? And in that case, like, you can get something called high cardiac output failure, right? So in the AV fistula, this 5 conditions that I have listed, okay, you must know, because sometimes, they tend to ask you on your exams. Like for example, they love asking of AV fistula or beriberi or even severe like anemia. In these 3 conditions, if they ask you something, right, you should think about there is a high cardiac output failure is there, okay? That's something that you have to remember. By definition also, we said that, look, whatever the cause is, right, there is a decreased cardiac output is there, right? And it's not meeting the metabolic demands of the tissue, right? And that is what results into what? Your heart failure. That's what we're talking about here. In this case, look, even the cardiac output is higher, right? In this case, but still though, it's not enough cardiac output for this, like for the metabolic demands of tissue, which is caused by this pregnancy or thyroid or beriberi or severe anemia or AV fistula, okay? Remember, pregnancy is not a pathological condition, it is a physiological condition, okay? So this is the one exception when you have a high output failure. Make sure you know this, right? And this is exception. But as I said earlier, whenever we talk about the heart failure, in generally, we're actually talking about this low cardiac output failure, okay? And remember, we said that there is what? Usually it happens in the left ventricle. There is a filling, the left ventricle filling time is a problem, ventricle filling is a problem, or there's ejections of the blood is a problem, right? And that ultimately is what? There is a decrease in cardiac output is there, all right? This is what happens, all right? Now, let's go and talk about a little bit about, this, how does this heart failure, what are this heart failure, how do we define, like let's say we talk about different types of actually heart failure, let's talk about that. Now here, when we talk about low cardiac output failure, right? Usually this type, which is the most common, okay? Now we're not gonna talk about this anymore, okay? This is all I have for you when it comes to high output failure. Now only gonna focus on this part right here. This type of heart failure, right? We have two types of heart failure, and we'll right down here. And you got to remember this, all right? I mean, actually, there are more than two types, but I'm going to go with like just basic here, all right? And generally, what is more clinically important? We have something called heart failure right here. This is a heart failure. But this heart failure is there's a reduced ejection fraction is there. So we write down here with R, and there's ejection with EF. What is this called? Sometimes they call this as clinically, okay, the types of heart failures. HAP-RAF, that's what they call this, okay? And this is where you have what? Depressed. You have a depressed or low ejection fraction is there, okay? And when we talk about ejection fractions, usually when we're saying the ejection fraction is less than 40%, right? The ejection fraction is less than 40%, right? This is what we call HAP-RAF. Now, the other types of heart failure is there. We call them this is another type of heart failure, okay? This is what this is a heart failure, but this, this ejection fraction is preserved. This is preserved. Ejection fraction is there, right? That means your ejection fraction is usually greater than 50% or so. It's a preserved ejection fraction. Then you might wonder, then what about in between? Okay, and there is another type of heart failure. We say that is called heart failure, and I'll just write it down here. But we know there's a heart failure, we say, and then it is a mid-range ejection fraction is also there. And usually this time the ejection fraction is from the 41 to 49%, all right? This is extra, I'm giving it to you. Now, when we talk about, let's just say HAP-RAF, okay, or HAP-PAF, what is this? This means that there is an ejection fraction is there, right? This type of heart failure where the ejection fraction is less than 40%, right? This type of heart failure, we call them a systolic. This is a systolic heart failure, or there's a systolic dysfunction is there. So this is a systolic heart failure. When there is a heart failure, but the ejection fraction is preserved, then we call them it has nothing to do with ejection, it has to do with more the diastolic. So this is a sort of like a diastolic heart failure, right? Now, we don't commonly use systolic heart failure, diastolic heart failure nowadays. In your clinical rotation, like you might hear a lot of times they say HAP-RAF or HAP-PAF, all right? So this is the difference, and this is what we're going to talk about. Now, one thing that you should know is that whatever the cause, whether it's a HAP-RAF or HAP-PAF, right? One thing that you should always remember is we're talking about the ventricles, right? There's always an increase in pressure is there. So there's always there's an increase on the left ventricle and diastolic pressure is always there, okay? No matter what type of heart failure you're talking about, either systolic or diastolic heart failure, there's always a increase in left ventricle and diastolic pressure is there. This is gonna cause much more problems, and we'll talk about why there is there, but remember, this pressure is always increasing. It's all this type of heart failures, right? You've got to remember this. Now, when we talk about the systolic heart failures, right, we got to talk about what are the common, what are the causes that are leading to systolic heart failure? What are the causes of the that leads to this diastolic heart failure, right? That is what we have to talk about. Now, whenever we talk about, let's just say, now we'll go with the systolic heart failure, or we'll write down HAP-RAF, okay? So we'll write down HAP-RAF. If we write down, let's just say HAP-RAF, we're talking about the ejection fraction being less than 40% here in this case, right? What are the conditions that can result into less than 40% of ejection fraction? That's what we're talking about, right? Usually, one of the most common cause of the reduced ejection fractions, our systolic heart failure is, remember, systole means contraction, right? That something has to do, there's impairment in the contractions. That is what can result into, right? So there's something called, we can say, impairment on the contractibility. Contractibility is there. Now, what are the causes of the impairment of the contractibility of the heart? The heart is not contracting enough to propel enough stroke volume, right? So if you're talking about this one, usually it is MI, okay? Myocardial infarction, you've got to remember. Some sort of ischemic cardiomyopathy. We can even write down this as a ischemic cardiomyopathy, and that's one of the most common cause that can result into something called dilated cardiomyopathy, which can cause heart failure, okay? Now, MI is there, or ischemic, let's just say ischemic, myocardial, we'll just write down there like this, okay? This one, impairment contractibility, right? Now, not only this can cause it, other one is for example, there is Your volume of the ventricle is overload, right? There's a chronic volume overload is there. Maybe like some sort of valvular heart diseases, like for example, you could have a regurgitation, like a mitral regurgitations, or third would be like aortic regurgitation. Even this case, like mitral regurgitations or aortic regurgitation, what happens? There's a chronic volume overload is there. And on top of this, what happens is that maybe third, like there's a left to, let's say right shunt, and this is usually like congenital heart diseases. All of them result into what? There's a chronic volume overload is there, all right? So volume overload, right? Chronic volume overload can also result into what? Heart failure with a reduced ejection fraction, down. So these ones are very important, all right? Now, you gotta remember, so I can write down this as, okay, I can make this as a number 2. And number 2, I could say that maybe there's a condition that results into chronic volume, right, overload. And then you can make this as like, okay, there are the different conditions that can lead into chronic volume overload, all right? Now, third is that maybe there is some kind of non-ischemic, okay, non-ischemic dilated cardiomyopathy is there, right? Now, what does this mean though? Usually non-ischemic dilated cardiomyopathy, where your ventricle becomes dilated because of volume overload again. But remember, this is non-ischemic. That means that usually this could be caused by, like for example, let's write down here. It could be caused by, like for example, alcohol. Okay, that can result in dilated cardiomyopathy. Or let's just say there is a, like a Chagas disease is there. Or let's just say myocarditis. There's inflammations of myocardium that can result into dilated cardiomyopathy, and that can result into heart failure, right? That could be this. Or maybe let's say there's a cocaine use is there, chronic cocaine use. Or let's just say drugs like doxorubicin drugs, okay? All this can result into something called dilated cardiomyopathy, which can result into heart failure. One thing that you should always remember is that whatever any of this causes, right? Usually, if the reduced ejection fraction is there, there is some form of dilated cardiomyopathy is there in order to cause a reduced ejection fraction that is less than 40%, all right? Now this is what? This can result into what? All decrease in what? This can result, all this condition, right, this can result HAPRAF, okay? That's less than 40%. Now, after this, there is also, but remember, this is a problem with the contractibility, right? Now, other condition you can have, maybe let's just say something called, there's an increase in like a afterload is there, right? Afterload is there, all right? Afterload is there. And this can also reduce what? This can also decrease the ejection fractions. Now, what are the conditions that can that have an increased afterload? One is like, let's just say you have hypertension, but this is like a severe type of hypertension. The chronic hypertension is there. Or let's just say there's a valve, like for example, aortic stenosis is there, right? That causes increase in afterload, right? That means the ventricle has to generate higher pressure to what? To propel the blood out, and that can reduces the ejection fractions, and even this can also what? Causes HAPRAF, right? So these are the causes which can lead into what? Lead into what? HAPRAF or systolic dysfunction. All these conditions that I wrote down here, these are what? Systolic dysfunctions which result into HAPRAF, right? Now, after this, I also have to talk about the conditions that can result into, now we're going to write down HAPAF, right? And what is it? This is a heart failure, the preserved ejection fractions, or this is, we're talking about the diastolic. This is a diastolic dysfunctions, right? Now this is different from all these other conditions. And here, these are what we talk about. And usually in this condition, right? Look at this ventricles, right? If you look at this, it has no problem with the ventricle contractility. What happens is there is some sort of, like right here, there is this guy, this myocardium, this ventricle, this become thickened, right? They become thickened. They can become very, very stiff. So the ventricle is not proper, his ventricle is not relaxing properly. So that when they try to accommodate the blood volume, right? During a relaxation, they cannot accommodate the blood volume. So it's because of because there's stiff blood volume is there, right? I mean, stiff ventricle is there because of some sort of infiltrative condition. The ventricle becomes restrictive to be very, very specific, right? Like your left or right ventricle, that's what happens. So but even though like, your ventricles are stiff or firm, but usually they have a preserved ejection fraction, which means that they have an ejection fraction that's usually normal, All right, that is something that you have to remember. Now, what are the conditions that can result into which a preserved ejection fractions or diastolic dysfunction? That's another type of what? Heart failure. And in this case, right, we're talking about basically the, like, for example, let me write down, like restrictive cardiomyopathy. Like, what are these conditions? Like, for example, in this case, like maybe sometimes there's amyloidosis, right? That can get deposited into this myocardium, right? And that can make the ventricle restrictive. And what happens? And ventricle would not be able to relax. Or let's just say maybe there's condition like, for example, there's an endocardial fibrosis. There are a lot of fibrosis is there, right? This one, usually this is seen most commonly seen in like children who are less than 2 years old. This one, right? Amyloidosis, endocardial fibrosis is there. Or maybe like, for example, I'll write down to here. There are hypertrophic, let's just say, hypertrophic obstructive cardiomyopathy is there, all right? Even in this case too, like hypertrophic obstructive cardiomyopathy. Somehow, like, let's just say, this ventricle septal, right? This become very, very like thickened, plus the ventricle mass has also become thickened, right? And that basically makes the, ventricle become very firm and stiff, and they would not be able to relax properly, right? And that can result into what? There will be decrease in what ventricle filling, right? And it's because of that, they'll propel the less cardiac output, maintaining the ejection fractions, but still what happens is that this results in something called diastolic dysfunctions. This one, or like other condition, like for example, you'll study this, like for example, there is considered acute, or let's just say constrictive pericarditis is there, right? Even condition like constrictive pericarditis, like the pericardium become very, very inflamed and they become constricted, right? And that causes what? That makes the ventricle become very firm and stiff. That's what it becomes. Any sort of infiltrations, right, that causes the ventricle is unable to relax, like for the restrictive cardiomyopathy, hypertrophic cardiomyopathy, acute constrictive pericarditis, or let's say other condition, like for example, there's something called cardiac tamponade, right? Even in this case too, there's a lot of fluid gets accumulated on the pericardium of the heart, like for example here. This is a pericardium, right? Like for example, this is a serous layer, a lot of fluid, but then this fluid, this is called pericardial effusions. But when this pericardial effusion started compressing the heart, right, that causes something called cardiac tamponade. And when that means if because blood volume is too much, there's edema is there, and there's compressing the heart. When when the ventricle relaxes to accommodate more volume of blood, it would not able to do it because there's a compression of the heart is there, right? So please remember, what are the conditions that can result into what? HFpEF, which is restrictive cardiomyopathy. Like for example, condition that can lead to amyloidosis, endocardial fibrosis is there, or sometimes post-radiations of that can cause too. Or like something called low floor syndromes. What is low floor syndromes? The low floor syndrome is something called, here, let me write down low floor. LOEF, low floor syndrome. This is where like a lot of this hypereosinophilic, this is called low floor fibroelastosis, and that's what it's called, okay? And in that case, what happens is it's called low floor fibroelastosis. In this case, there's a lot of eosinophils there, right? A lot of hypereosinophilia is there, and those eosinophils come, right? And they can start producing like different proteins, like major basic proteins, and they start destroying myocytes, and it becomes like the myocytes become very fibrosis and all, and eating. Like, so just for now, what you should remember is that any condition that is restrictive, right, that is infiltrative in nature, right, that causes what? Stiff ventricle, that can result into HFpEF. Even sarcoidosis can cause it. Even hemochromatosis can cause this, right? So these are just an extra I'm giving it to you. Now, so far we have been discussing about the HFpEF and HFrEF. These are the causes, right? They're the causes of, like, all these causes are that can result into HFrEF, and these are the causes that result into HFpEF, right? Now, after this, and you've got to know these causes, right? After this, we have to talk about, we have been discussing about these ejection fractions and all. What is this ejection fractions? We have to define some terms here, right? Now, if you're looking at the pressure volume loop here, right? Now, what is this? Usually, this is the time, right? This is the time all the way down here. We call this what? All the way up to here, we call this a end diastolic volume, correct? And this, you see later, is going up like this. This is what is called end diastolic pressure, right? Now, what is this point right here? This is what is called end systolic volume, right? That's what it is, end systolic volume. Now, this is the phase where what happens? A mitral valve, right? Mitral valve closes, correct? Mitral valve, this is a basic feature, mitral. And what happens is that, and this is a aortic valve right here, aortic valve. In aortic valve, this is mitral valve, right? This is the area where the mitral valve closes right here. When the mitral valve closes, what happens? The ventricles start contracting. This is what is called isovolumetric contraction right here, right? Isovolumetric, right? Contraction is it. Then this is where what happens? Aortic valve opens up, right? Now, when the aortic valve opens up, what happens? This is what ejection freezes, ejections of the blood, right? This is a rapid ejection and a slow ejection of blood, right? And what happens as this time when it comes, this is where the aortic valve closes, right? This is aortic valve closes. And this is what the isovolumetric relaxation is happening. This is what the mitral valve opens up, right? And this is what rapid passive ventricle filling. Then after that, you have end-systolic volume is there. Then you have a rapid passive and a slow passive ventricle filling is happening, right? This is the area where the ventricle filling is happening. Ultimately, is what all this blood that remains before the contraction, before the isovolumetric contraction happens, before the ventricle contraction happens, right? What do you call them? We call them end-diastolic volume, right? Or we call them a preload. Now, this is very important. You gotta remember some of the definitions here, right? Now, what is preload? Okay, preload. Preload is what? Amount of blood is present on a ventricle, present here, right? Before the systole, before the contraction, right? That's called preload, correct? Preload is directly proportional to end-diastolic volume, right? Or we can simply say end-diastolic volume is there. This is the volume where the ventricle is going to contract, right? That's what's going to happen. That's a basic physiology I'm going over. Now after that, what is the concept of afterload here? Afterload, right? Preload is before the ventricle contraction. Afterload is that, okay, this is the blood, the end-diastolic volume, right? This is the volume in which ventricle has to contract. So this is more like a ventricle is contracting during this blood, okay? During the systole, ventricle has to contract for this load, okay? That is what afterload is. And the contractibility is that the contractions of the ventricle to propel this blood, right? That's what it is. Now, whenever we talk about, let's just say, for example, when we talk about, there's a concept of stroke volume, right? What is stroke volume? Stroke volume is what? The stroke volume is amount of blood, right? Or amount of end-diastolic volume, right? This is the end-diastolic volume, amount of end-diastolic volume that gets eject per systole, per each contractions, amount of, that's what it means. Amount of blood that get ejected out in each contraction or each systole, that is what is called stroke volume, right? And how do I determine stroke volume is this. So you just take end-diastolic volume, right? And you do minus the end systolic volume, right? So in this case, what happens is, look, normally we're talking, this is a 120 ml, right? That is your end diastolic volume, 120 ml of the blood minus end systolic volume is 50, right? What does that give you? This gives you 120 ml, that's give 70 ml of the blood, right? Normal we're talking about, okay? Because you have to understand normal physiology before you got the pathology. And remember, this is a physiology, but I'm reviewing this, okay? Because without understanding this, you're not going to understand the heart failure. So it's a good review here. This is stroke volumes, right? So now, after this, we have been discussing about something called ejection fraction, right? And what is ejection fraction? Look, this is the ejection fraction right there. Now you have to remember, ejection fraction is this, that, look, the fractions of, look, it's usually, look, let me write down here. It's a stroke volume divided by end diastolic volume. This is what it is. So this is what ejection fraction. The fractions of, okay, the fractions of the end diastolic volume that gets ejected per systole. That is what ejection fraction means, okay? Ejection fraction is directly proportional to your stroke volume. Because ejection fraction is what? It's a fractions of the end diastolic volume. That is what ejecting per systole or per contractions. In each systole, that's what ejection fraction is. So for this case, right, what is ejection fraction? We say that stroke volume is what? Stroke volume is 70 ml of the blood, correct? 70 ml of the blood. So you do 70 divided by, what is end diastolic? You do 120, right? This is ml of the blood. So what do you get? 70 divided by 120. You should be able to get, if you do math correctly, you should be able to get like 58 I already did this math, but it should be 58.33%. See, this is an ejection fraction. And now you have to know what is the normal ejection fraction. Usually anything. Different books might say different things, but just know that it's usually greater than 50%, and you can go all the way to 75%, okay? So that is a normal. So write down, normal is like, okay, greater than 52, we can take to the 75% ejection fraction is usually normal ejection fractions. Now, this is the definitions you have to know. Ejection fraction directly proportional to stroke. Now, then after that, in here, if you look at this, this is the graph, right? This is all the way down here from the end oscillator volume to end oscillator. This is what determines your stroke volumes. All right? Now, after this, you also have to know the definition of something called cardiac output. What is cardiac output again? Cardiac output is what equal to stroke volumes times the heart rate, right? Now, what is cardiac output? Stroke volume times heart rate. Now, the stroke volume is what? Amount of blood, right? Amount of end-diastolic volumes, right? That is getting ejected per systole. Amount we're talking about, right? Not fraction. That's what stroke volume is. But if you say number of minutes, right? So if you say the amount of blood that is getting ejecting out per minute, then we call them what? Cardiac output. That is what is the cardiac output. So cardiac output is directly proportional to stroke volumes. Cardiac output is directly proportional to heart rate. So think about it. If you increase your stroke volumes, you increase your cardiac output. That's how it works, right? So like if you increase your stroke volume, you increase your ejection fraction, right? That's what it does. Your ejection fraction is inversely proportional to end-diastolic volume. So you gotta remember this correlation. It's a very, very important concept, all right? Here, cardiac output, and you just have to do, like, for example, if your stroke volume is like 70, right? You're 70. Let's just say 70 is there, and your heart rate is, we can simply, what is the heart rate? We can say it's a 72 beats per minute. If you multiply this together, right? This is 749, right? So this is what it's going to give you your cardiac output, right? Whatever that number comes in, you can do the math, and that would be a normal cardiac output. All right, that's your normal cardiac output within the physiological limits. Now, after this definition, right, we have to make a concept of, let's just say, in generally, right? In generally, what happens? So, if you want to, let's say, for example, let's just say that if you want to increase like a preload, let's say within the physiological limits, how does this pressure volume loop graph shift? Increasing preload means what? You're adding the blood volume, right? That means that, look, if I make this concept right here, like for example, it's a normal for A, there's a B point, you have a C point, you have a D point, right? In the normal, right? If you, let's say you're increasing a preload, okay? You're increasing preload. If you increase the preload, that means that what happens is this graph, right? Your end-diastolic volume will go up, right? So I can make this as, look, and pressure will go a little higher like this. It will go like this, right? And then, oh, look, the preload goes like this, right? And I can make this graph, look, it will go something like this. Look, this is normally, okay? That means that the B graph, this is like, this shift to what? B prime 1, look at this, you can think of it that way. What is this? This means that the mitral valve, this is what the mitral valve closes, right? It is actually closing a lot more higher pressure now, right? Because there's a volume is a little more, higher volume is there. And plus, because it's a little bit high, they have to generate a little more pressure. So this C graph also produces C prime 1, right? So this isovolumetric contraction moves towards the, what is it? Towards the right. Isovolumetric contraction moving towards the right, okay? This is what is happening when there's a, this is what? Increase in a preload graph, right? And what happens? That means that, look, based on the Frank-Starling law, the more you put the blood, the more will it eject, right? But remember, within the physiological limits, that's what happens. This is a preload. This is a normal I'm talking about here. Okay? Now, if I say, let's say, for example, if you increase the afterload, right? If you increase, what happens to increase the afterload? Think about it. If you increase afterload, there's no problem. You're not adding extra volume, so this graph is not going to shift here. We can make a graph like this. It's going to go all the way down here, but this will go all the way down up to here. Look, if you increase afterload, right? Okay, you know what? I'll make this increase afterload here, pressure volume loop graph here, different. So look, let's just say make a normal, right? This is a normal, right? Look, this is a normal, okay? Pressure volume group. If this is a normal graph, if you generate pressure, like for example, there's aortic stenosis is there, right? Let's say for example, there's a chronic hypertension is there, right? That means that look, this point is A point right here, this is a B point here, this is a C point here, let's just a D point here, okay? What happens is, look, this is not problem with this one. Problem is more like a pressure. Pressure, you have to generate enough pressure to come down here. And what happens is that the graph will go like this and comes like this. That means that what happens to C? C moved down here, C prime 1 right here. It went up, the pressure has to, you have to generate enough more pressure to generate open the what? Aortic valve. Plus this graph was, this was open here, like here, around the 100, right? That was open here. So our aortic valve was closing around the 100 millimeters of mercury, that's the pressure, right? But now, it has to generate, it has to move down here, which is let's just say this is a D prime 1. So it means that the graph has to go this way. So what is this? This is an isovolumetric relaxation phase, right? This is moving to this direction. What is that? What is this direction? These are right directions, right? This is where it's moving. Pressure is going up, C from the C prime 1, and from the D to D prime 1, that's what's going, right? So this is a shift. This is the graph you see, this is usually you see this in your what? Aortic stenosis, or maybe the chronic hypertension is there. Okay, this is the graph you see. So you got to remember what happens C to C prime 1. Okay, and you got to remember D to D prime. Okay, what is happening? And remember, because of what happens, there is a decrease in what? Stroke volume is there. There's a decrease in stroke volume. If it decreases stroke volumes, like what happens in SSI volume and SI volume, we haven't talked about that too, right? And we'll talk about this when we discuss about the heart failure. But now, remember, this is a very, very important concept here. Now, I'm going to come back and talk about this a little later, but let me talk about the contractibility actually here. That's a preload graph I showed you. Let me make a contractibility graph, okay? And I'll make let's just say, within the physiological first, okay? So there's a point here, there's a point here, there's a point here, right? Now, if your contractibility increases, right? That means what happens, this graph will go like this, right? And you contract so vigorously, it will go like this. Look at this. What is happening in the contractibility is this, that this graph, right, is shifted to the more toward the left, because this graph, like if I make this, right, if I make this contractibility right here, right, it'll go like this, go all the way down, right? It'll come and all the way come down here like this. What means that it is going to propel more blood out. It's going to propel more blood out. It will come down here, maybe like up to 40, right? So your ancestral volume would be probably 40. That would be, right? So that means it is throwing what? When you have an increase in contractility, it is what? It increasing your cardiac output. That's what it's doing in this graph, right? And you don't believe me? Yeah, let me do it. Let me do it. This graph, right? We're talking increase in contractility. You're what? There's a endostal, which is 120, right? Minus, what is this? You do 40, right? 120 minus 40, what do you get? 80 ml of the blood. See, you're throwing 80 ml of blood. This is stroke volumes, right? Stroke volume is what? 120, your 40 ml of the blood is stroke volume. What is it? That's 80 ml of the blood, right? You're propelling or you eject 80 ml of the blood by increasing contractibility, right? So what has happened? Your stroke volume is usually what? It's 70 ml, but you're throwing 80 ml by increasing the contractibility of it. Now think about it. The preload also, let's make this. I'll make this one here. It was 130. It was this, right? Let's just say this is when you have increased the preload, right? What happens to the pressure volume load? There's a 130 is the ml of the blood, minus it also able to throw all the way down here, right? The more you get, the more you stretch the myocardium, the more it will throw out, right? Based on the Frank-Starling law. And it still is able to eject all the blood, and you have remaining what? The graph is about 50 ml of the blood, right? So what is this? 130 minus 15. That is also like about 80 ml of the blood, right? It's still throwing the what? Okay, let me do the math. So you have a 130 minus 80. 130, right? Minus 50, yeah, 80 ml of the blood. See? By even increasing the preload, right? And this usually happens, like, for example, this is more like a physiological conditions, right? But in the pathological condition, this graph is going to switch. It's going to look differently in heart failure. But you have to understand this curve. What happens to from the, let's just say, B point to C point, you've got to know this first, normal first, all right? Now, let me come back and talk about, let's say, for example, we're talking about this afterload thing, right? This is a little more different here. When we're talking about this HAPRAF, right? When there is a volume is overload is there, and then when the pressure overload is there, there's a changes that happens in myocardium that's very different from one another, right? And let me quickly talk about this. And this is an important concept here. Like, for example, let's just say this is a normal graph right here, right? Let's just say this is a normal pressure volume curve graph, okay? This is a normal pressure volume curve. This is a point right here. You got to remember. When, let's say aortic stenosis is there, right? Aortic stenosis is there. That means that it has to, the ventricle has to generate enough pressure to open here. It means it has to go all the way down here. But then this valve closes very rapidly too, right? And maybe like point here. So what happens is like this graph. You see this is the point you're seeing right here. So if I'm making like A here, there's a B here, there's a C here, there's a D, right? What happens to this? The C go into C prime 1, the pressure because the pressure overload is here, and the D go into D prime 1, right? And what happens to stroke volume? This is something we've discussed about. Normal is this. All the stroke volume is here, right? Normal is this. So this, you can simply say this is a 120, and this is, you can say 50, right? 50. So in here graph, if I make it, the pressure overload, right? This is what is happening here. And I'll make this, so you know. Yeah, I'll make this in here. It is opening right here and coming in like this, right? So now think about it. This is a graph, okay? So now think about it. In this case, normal is what? Our 70 ml, right? We have a 120 ml of the blood, correct? Minus, look, it is opening here, like this one. Right? We can simply, this is 80, okay? So for understanding purpose. So this 120, the stroke volume is what? One endostolic, which is a endostolic volume, which is 120, minus end-systolic volume, remember, is what? 80, right? That means what is stroke volume? 120 minus 80, that's a 40 ml of the blood. See, you see that stroke volume decreases. So if your stroke volume decreases, what happens to cardiac output? Cardiac output is also decreases because what? Cardiac output is also decreases because stroke volume is directly proportional to cardiac output, right? Now think about what is happening to ejection fraction. Think about ejection fraction now. Okay, ejection fraction. What is ejection fraction is equal to? Stroke volumes times what? Endostolic volume, right? So if you do 40 is a ml of the blood, is stroke volumes, and you do endostolic volume is 120, right? That's the endostolic volume. So if you do 40 divided by, let's just say, if you do 40 divided by 120, right? That gives you 33.33%. 33.33%. Now think about 33%. The ejection fraction, what is the normal we said? Is usually from 50 to 75%, right? Now look at this. Ejection, in this case, in aortic stenosis or some kind of cardiac hypertension, what happens? There's an increase in afterload is there, right? There's a have to generate enough pressure. So because of this, what the HAP-RAF condition is there. Look, there's ejection rate less than 40%, right? Now that is what is resulting to systolic heart failure. Think about that. That's what happens here. Okay? Now, but this one, but in the aortic stenosis or let's just say there's a chronic hypertension, like severe chronic hypertension, there's an increase in afterload. That means that this is a problem with what? This is a problem with the pressure. Okay? This is a problem with the pressure. When you talk about the impaired contractibility, or let's just say the chronic volume overload or dilated cardiomyopathy, what is the problem here is that the volume overload is there. Okay? These are the conditions, like, that result into what? Volume overload. Okay? Your ventricles has a more volume of the blood is there, right? So when there's a more volume of the blood, like just there's a lot of blood is there, like all the way up here, the pressure is also going to go up, okay? The pressure is also going to go up because based on the Laplace's law, okay? What is Laplace's law said? Laplace's, right? He says wall stress is equal to what? Pressure times radius over the 2 times thickness, right? When there's a more increase in pillar, that means there's more stress on this one, right? That's what happens. That results in increase in radius, right? And that directly provides the more radius, that's also going to generate more pressure to that. So that is what it means, right? So you got to remember, this is a very, very important concept, all right? It's a very, very important concept here. When there is a chronic volume overload is that usually what happens, let's just say this is a ventricle, okay? I'll make a simple diagram. Let's just say this is a ventricle right here, okay? And what happens if there's a ventricles is, and this is a normal lumen is there. If there's a volume overload is there, right? Then what happens is this volume, right? They become more dilated like this, okay? They become more dilated. This is called, that means there's a change, when increase in what radius is there, okay? This is radius. The reason why this happens is that when the chronic volume overload is there, the cardiac myocytes, they started arranging themselves in a series, okay? The sarcomeres, they started adding in more in series. So now this is a very, very important concept, and your board exam will always test you on this concept, okay? So now remember this. When there is a chronic, and we're talking about the HAP-RAF thing, okay? So when there is let's just write it down. When there's a chronic, right, volume overload is there, right? You have this myocytes, correct? Let's write down here. This myocytes, like let's just say, okay, we're making of ventricles. Let's just say this is okay here. This is a this is a normal, okay? Let's just say this is a normal. If there's a chronic volume overload, this becomes like this. You see, there's a lot of dilation is there compared to this one. And this has happened because your sarcomere, you know this sarcomere? Here they added, this is a sarcomere, let's just say this is a sarcomere. This sarcomeres, right? What happens is these guys add, okay, we'll make sarcomeres in different one. You know, like you have something called like this, you have like this, and in between that you have a, like this, right? So, usually in this case, what happens is this, like, you know, sarcomeres are added in series like this. Let's say this is a sarcomere, this is a sarcomere, like this. What is happening here is this. Okay, look, this is what happening here. 1, 2, 3, all right, this is one here, like this, all right? And in between that, what is happening here? There's a myosin is there. Look, so this is adding in more in what? Series. Please remember this. When you add sarcomeres and more in series, that result into what? Dilated cardiomyopathy. Because why that is happening here is because why is happening here is this, that why this is happening? Because the radius has been increased, because the chronic volume overload, they get stretched, right? And that is why, please remember, the volume overload always result into sarcomere adding in series, and this type of, this type of condition, we call them eccentric. Eccentric hypertrophy is there. You gotta remember this, okay? This is a very, very important. Chronic volume overload result into eccentric hypertrophy where the lumen cavity is increased, right? Increase in the left ventricular cavity is there because there is what? The ventricular myocytes are adding in series in a volume overload. That is called eccentric hypertrophy. And you can see that in a chronic ventricular regurgitation, dilated cardiomyopathy, you can see that, okay? This is resulting in eccentric hypertrophy. You gotta remember, this is a very, very important concept, all right? And the lumen become very, very large. Increase in the left ventricular cavity because again, sarcomere are adding in the series. So important, they always test you on the concept, so you gotta remember this. Now, if this is a normal, right? Let's say that if there is a pressure overload is there. This is a normal again, okay? This is no. If there's a pressure is overload is there, right? Then what happens is that, you know, like for example, in pressure overload, like for this condition, increase afterload, hypertension or aortic stenosis is there, right? Or even in restricted condition, what happens is this, that, you know, if this is normal, this is the ventricular cavities here, what happens, you know, look, what happened here, look, and this is happening in where? In the condition like hypertension or aortic stenosis. Please remember this, please. Aortic stenosis, or let's just say hypertension, right? The left cavity or the ventricular cavity becomes smaller because this is what? There's a pressure overload, okay? And in the pressure overload, what is happening here is that this ventricular myocytes, right, specifically left ventricle, the cavity becomes smaller, right? And I'll show you a picture of this too. But in the pressure overload, really what happens is that there's a lot more increase in pressure, right? That causes the ventricular myocytes to become thickened. Okay, and we call that thickened, it's called hypertrophy is going to happen. But this type of hypertrophy is not an eccentric hypertrophy because in order to be eccentric hypertrophy, the sarcomere has to be added in a series like this, like this, like this, like this. So it becomes, you know, it becomes prolonged like this. Your ventricle cavity becomes prolonged, right? But in this case, you know what happens is that these guys, you know, in the aortic stenosis or let's say in hypertension or even restricted cardiomyopathy, right? What happens is this, that these ventricular myocytes get thickened, but they are added in more in series. Like sarcomeres are, let's just say, added in series. Look at this. Okay, I'm just going to make this like this, okay? What is this? Okay, I'll just make this like this. This is how they're added. This is a parallel. See, this is a parallel sarcomere adding. This is how it looks like. So when the parallelly when the sarcomere is added, right? That usually happens in where? In the hypertensions or in the aortic stenosis because there's an increase in pressure. Remember, increase in pressure overload, right? Increase in pressure lead into, okay, sarcomere adding in parallel fashion that result into something called concentric hypertrophy. All right, And you gotta remember, in what conditions you can see concentric hypertrophy is whenever there's an increase in what? Pressure. And most commonly what? In the aortic stenosis and the chronic hypertensions, okay? In hypertension, because there's what? Increase in afterload that result into sarcomere adding in the parallel, result into concentric hypertrophy. And the left ventricle cavity become smaller, okay? The left ventricle, this cavity become very small. And what happens? As this become hypertrophy, right? As they start to become hypertrophy, they become more thick and thick, right? Slowly, you know what happens? They start getting dilated, and that can result in dilated cardiomyopathy, okay? And resulting into heart failure. You gotta remember the eccentric hypertrophic and concentric hypertrophy because your board examiner love to test you on that, okay? And I repeated this so many times because you gotta know this, okay? You gotta know this, please. You gotta know this concentric and eccentric hypertrophy, and in what condition that you see that. You need to know this. It's very, very important. And make sure you know this pressure volume loop curve graph. It's so much important, right? And here, so far, we talked about more in physiology and one pathology of the aortic stenosis or hypertension, or when there's increase in afterload, what happens to stroke volumes and what happens to ejection fraction. We talked about that, right? Now, I'm going to talk about one more thing. You know, we didn't talk more about the HAPAF, right? This is with the diastolic dysfunction. But we talked about, but we have to talk about there's a preserved ejection fraction, right? That means what is this? The problem is there is what? In what is the condition? Restricted cardiomyopathy or amyloidosis is there, right? Some sort of infiltrable condition is there that is making the ventricle firm, right? So what happens to the ejection fraction? In that case, look, this is what happens. Look, this is a 120 ml, right? The blood. That's what normally before the ventricle contracts, right? This is the normal amount of volume, right? At least in our diagram. What happens is usually in the diastolic dysfunction, where there's a ventricle filling time has been compromised, okay? Ventricle is not able to fill the blood. So in that case, you know, this maybe it's not filling 120 ml of the blood, which is supposed to be. Maybe it's only filling maybe like right here. We can simply say this is about 110 ml of the blood it's filling, okay? Let's just say it's only filling 110 of the blood, right? And if they're filling the 110 of the blood, that means a less preload, that means a less what? Think about it. If there's a less preload is there, your stroke volume is what? Your stroke volume is determined by your preload, your afterload, preload, afterload, and also contractibility, right? Think about it. Based on the Frank-Starling law, you have a less amount of blood, your ventricle contract less blood out, right? That's what happens. So we can think there's a decrease in preload, and then you go all the way graph, and maybe like, let's just say maybe it come all the way down. Maybe we can simply just say, maybe there's, look, ancestral volume is maybe like around the same. We can simply say like, okay, maybe let's just say from here, it come here like here, around 60. Okay? So in that case, what happens is like, you have a 110, right? What is ejection? Look, remember, this is a diastolic we're talking about, okay? We're talking about HAPAF, right over here. HAPAF we're talking about. Let's just say that this is usually it's supposed to fill the 120 ml of the blood, but only fill like 110 of the blood, right? And then if you have stroke volume, this is what? And diastolic volume, which is 110, minus let's just say that, you know, less blood, less propelling out. So we can simply say maybe it propelled up to here, like 60. So what is this? 110 minus 60, give it to you. If you do 110 minus 60, or you know what, let's make this even easier. You know, there's a less decreased blood. Let's not even change anything. We have only, let's just say, because of the diastolic filling time, right? The diastolic dysfunction, the ventricle is not filling properly. It fills the less blood, but let's just say it's able to eject normal because there's no problem with the contraction. It throw out 50 ml of the blood, right? So let's just say our filling is 110 and diastolic volume, but it throw 50 ml of the blood, right? So we need to, what is 110 minus 60? That is 110 minus 50, that's 60 ml of the blood, right? So what is this 60 ml of the blood? This is stroke volume. Stroke volume is what? Directly proportional cardiac output. That means that your stroke volume is directly proportional. Our normal is 70 ml, right? Our normal is 70. But it decreased the what? Stroke volume, right? Stroke volume is directly proportional to cardiac output. That is why your cardiac output is also decreased. So that is why I said earlier, no matter what type of heart failure you have, either HAP-RAF or HAP-PAF, you still have what? Decrease in what? Cardiac output. This is a very, very important, right? Obviously, one of the exceptions is high cardiac output failure. Now, if you do ejection fraction, right? Ejection fraction is what? Your stroke volume is directly proportional to stroke volume divided by what? N diastolic volume, right? So you do 60 ml of the blood over the what? 110 ml of the blood. So if you do 60 divided by 110, right? What do you get? 60 divided by 110. You get 54.5%. Now, look, What happens is ejection fractions. Normal is from 50 to 75, right? That is why. So you have a normal ejection fraction. This ejection fraction is preserved in spite of having what? Low stroke volumes or low cardiac output, right? And this type of heart failure, we call them what? Preserved ejection fraction. The reason why that happens is, look, there is a 120 is supposed to be our normal, right? That is what ventricle usually, in a normal conditions, usually ventricle have, like your preload is about 120 ml of the blood, at least in our diagram, right? Before the contraction, right? That's a preload in diastole. But because of the restrictive condition, because the firm ventricle, it can only hold what? 110 ml of the blood. But still it's able to eject. Like, the 50 ml of the blood. So that is what? 110 minus 50 give you 60 ml of the blood. This is an end-systolic volume, right? And then by doing stroke volume divided by end-diastolic volume, you get 54.5%. But remember, your normal cardiac output is 70 ml of the blood per minute. Your normal stroke volume is what? 70 ml per systole. But there is a decrease in stroke volume because you have a decrease in what? You decrease the volume of the blood. You decrease the filling. Your ventricle did not fill all the way up to 120, right? And that is why when it propels the blood out, it propels the less blood out. That's why you see a decreased cardiac output, decreased stroke volume, and the stroke volume is directly proportional to your cardiac output. When you decrease the cardiac output, that means that you're not meeting the metabolic demands of your tissue, right? That's what's happening. And that results into what? Heart failure, but that is a heart failure, preserved ejection fraction failure, or diastolic dysfunctions. Now, one more thing, sir. As I said even earlier, no matter what type of the heart failure, in this case, right, in this two, there's a decrease in cardiac output. Plus, if there's a decrease in cardiac output is there, there's one thing, right? Plus, there's also increase in end diastolic, okay? Left ventricle end diastolic pressure is always going to increase. So there's an increase in what? Let me write it down here. This pressure right here, we already wrote it down here for you. This is also always increased. Left ventricular end diastolic. You got to remember, this is the hallmark of heart failure in both the conditions. And why? Left ventricular end diastolic pressure is higher. And why is this? No matter, look, if there is think about, if there's aortic stenosis is there, or there's impaired contractibility is there, right? Whatever it is. Look, the pressure, if there's a lot of volume overload is there, that means that the heart has to generate higher pressure, pathologically higher pressure to propel the blood out, right? That is why the end diastolic pressure is going to go high. If you're talking about aortic stenosis or chronic hypertension, severe hypertension, there's an increase in afterload. That means the pressure gradients change. You have to generate higher pressure, right? In order to propel the blood out. That's why the aortic valve is much more opening and much more higher pressure than what is supposed to be normal, right? So that's why the pressure goes up high in your let's just say heart failure with a reduced or depressed ejection fraction, right? In that case, you understand that point. When you talk about diastolic dysfunction, how the pressure goes up. Think about it. If the ventricle is very, very firm, like let's just say this is a ventricle, right? And this is very, very firm, right? If the ventricle becomes very, very firm, what do you think? The firmness, the thickness, right? Ventricle wall tension becomes very thin. Wall stress, look, there's a lot of wall tension stress is there, right? Because of thickness. That rises your pressure. And that is why the restrictive ventricle also leading to what? Higher pressures. Left ventricle end diastolic pressure. Because primarily we're talking about the left ventricles, okay? This is why you gotta remember the left ventricle end diastolic pressure is always gonna go up, right? Now, I'm gonna end it here for this. And next lecture, we're gonna talk about when there's an increase of left ventricle end diastolic pressure is there, right? What is gonna happen and how it's gonna lead into what? Clinical symptom. That's what we're going to talk about in our next lecture. But you gotta know, or at least remember this, the pressure here, okay? Please. Thank you.